AKI in cardiac surgery. I have no conflicts to disclose, and those are my objectives. And I'm going to start with the epidemiology, say a little bit about the pathophysiology and how we can predict AKI, the current problems we have with the diagnosis of AKI in cardiac surgery, and how new biomarkers can help us here, and at last, a little bit about strategies, how we can prevent and manage AKI in those patients. So, as we all know, AKI, or at least cardiac surgery, is quite common worldwide. We have more than 3 million surgeries performed worldwide, and AKI after cardiac surgery is the second most common type of AKI in the ICU setting after septic AKI. And the incidence, however, varies greatly. When we look at the literature over the past decade, and that is probably because of a lack of a consensus on the definition of AKI and that population that we're looking at. And the mean range of AKI is between 7 and 30%, and a recently published meta-analysis reported pooled worldwide incidence of 22%, while less than 3% require dialysis. And AKI is, and you all know that, associated with a huge mortality, short and long term, and that's why we care so much about these patients, with a mortality rate of about 10% for patients who develop AKI, and it may increase over 35% in those who require dialysis. And the high mortality rates are partly related to the fact that patients with increasing severity of AKI, they are more likely to develop further complications and injury of other organs, and that includes prolonged mechanical ventilation and coincident sepsis, which then affects the outcome of those patients. And, well, the risk remains high even 10 years after cardiac surgery and increases with severity of AKI. And this is also true for patients, despite they show a complete renal recovery, at least by definition of serum creatinine. And it is the highest for those patients who do not recover at hospital discharge. So that would mean patients who require dialysis at hospital admission. And this is a retrospective study, a match control study that shows us very nicely the high mortality that patients with dialysis they have. And here it was 64% 1-year mortality compared to 8% in those patients who did not require dialysis. And again, you see that strong signal that the mortality in those patients really depends whether they develop further complications like respiratory and cardiac support. And the other aspect that they looked at was renal recovery, and this is something that patients and family members very heavily focus on. When we bring the dialysis machine, they think it's permanent. We always tell them it's probably not permanent. And this study gives us the data behind that. So we all know the mortality is quite high among patients who require dialysis, but among those who survive, very few end up needing dialysis, at least 1 year after cardiac surgery. And the other aspect that they looked at was the timing of renal recovery, and it turns out that among survivors, at least by 90 days, they recover 66%. So it takes quite some time till they recover. But the main issue in terms of prognosis is the high mortality rate, which is comparable to patients in the ICU with multiple organ failure requiring dialysis. So now to the next point, pathophysiology. Well, AKI after cardiac surgery is complex and involves multiple factors. Some of them are related to the surgery itself. Some of them are related to the patients that we operate, and some of them to what happens to them before they go to the OR. And the main injury pathways, they include ischemia reperfusion injury, and it's probably more the reperfusion that causes AKI, the use of cardiopulmonary bypass, the non-pulsatile perfusion and hypoperfusion, inflammatory and oxidative stress, and use of nephrotoxins. And a factor that comes more and more into focus, and Professor Ioannidis already mentioned it, is right ventricular dysfunction and the role of congestion, although in cardiac surgery specifically, we don't have much data about that. So looking at AKI as a rather complex syndrome after cardiac surgery, it is unlikely at least in my opinion, that a simple solution like taking away the cardiopulmonary bypass is likely to have a significant effect of all these variables. And so it's, of course, always better to take a step back and try to identify the high-risk patient preoperatively, because we could maybe manage those patients more properly if we know which is the high-risk patients, and that includes surgical technique and how should we manage the patient perioperatively. So this leads us to the next question: what do we have regarding preoperative risk assessment? Well, there are several scores that have been developed and validated in a huge number of patients that predict AKI, but only requiring dialysis. And among those, the Cleveland Clinic score and the SDS score are the most commonly used, that have the best discrimination with a C-statistic about around 0.8. But as I told you before, AKI requiring dialysis is quite rare, so that really limits the use of these scores. And what we really need is something to discriminate more milder forms of AKI, patients who do not require dialysis. And that is something that's a really problem that we have nowadays. I mean, we all know that chronic kidney disease is the strongest risk factor for AKI. We don't need to do the scores in those patients because we know they will develop AKI. But what about patients who have a normal renal function or who appear to have a normal renal function? And the only test that addresses this need is the so-called kidney stress test. So why has a patient with a normal kidney such a capacity to tolerate injury without a rise in serum creatinine? It's called renal reserve. So we all know that when we eat a big steak, our GFR will increase, because the protein loading stimulates the kidney function. And it turns out that if the GFR doesn't increase, the patient lacks renal function reserve. And those patients are at high risk to develop AKI after cardiac surgery. So these are all patients who had a normal baseline GFR, although 1/3 of them had an impaired renal reserve, and those patients were remarkably at high risk to develop AKI. So this is something that we can do in those patients in our office before they go to the OR. And the other aspect of it is in those patients who develop AKI, so you see here the patients with stage 2-3 AKI, patient with stage 1 AKI, they all lose some of their renal function reserve 3 months after cardiac surgery. So it appeared that everybody, all of them had a normal renal function 3 months after cardiac surgery. Baseline GFR was back to normal, creatinine was back to normal, yet they have a defect when you provoke it with a kidney stress test. And interestingly, patients who did not develop AKI but had increased biomarkers, they had also similar decreases in renal reserve, whereas patients who did not develop AKI and did not have increased biomarkers, they had intact renal reserve. So it may well be the case that we think everything is fine, the patient has fully recovered. From the kidney perspective, everything is fine, go ahead. But it's still possible that they have lost a significant amount of renal function. And the only way you can find it out is to doing a kidney stress test in those patients. And that happens quite frequently in cardiac surgery as well as other conditions. And it turns out that although more than 2/3 of patients who develop AKI have an early reversal, many of those will have a relapse in the hospital, but they will recover, but also some of them will relapse, but they will not recover the renal function. That, of course, impacts the outcome of these patients. So now to the next point, diagnosis, biomarkers. We all know that diagnosis of AKI is not that easy because it takes some time till serum creatinine increases and that it reaches the threshold for the definition of AKI, and that you have to lose a substantial amount, up to half of the functional renal mass before creatinine bumps up. And particularly in cardiac surgery, we have the issue with the fluid loading from the priming step during cardiopulmonary bypass, which dilutes the creatinine and masks the AKI, at least for 24 hours. So ideally, we would like to identify the patient much more earlier before we can do it with traditional measures of AKI. And well, we can do this with biomarkers. And nowadays we have a variety of them, and many of those have been tested in cardiac surgery, which is actually a good scenario because we have predictable injuries to the kidney. The problem with the biomarkers is that the results also vary a lot, from clearly negative to very optimistic, and there are multiple reasons for that. First of all, it depends which biomarker we take. When we measure it, what is the outcome? Is it AKI? Is it a replacement therapy? And how is AKI defined? And, well, also, what is the type of injury? As it turns out that septic AKI may have a different kinetic on biomarkers than, for example, nephrotoxic AKI, and that really hampers the use of these biomarkers. And of course, they're expensive, we have to say that, and they're not available everywhere. However, there are multiple studies showing that patients who have a positivity to biomarkers, although they have no clinical AKI, that this is associated with worse outcome. So this is a nicely done study in cardiac surgery, testing different biomarkers, and as you can see, I don't have the pen, but that's, there it is. As you can see, is that the mortality rate in the highest tertile of those who did not develop AKI is approximately the same like the lowest tertile of those who developed AKI. So measurement of biomarkers seems to make sense, as it better helps us to categorize the patient, the prognostic of those patients. And having said that, currently the most promising biomarker seems to be TIM2-IGPP7 to predict cardiac surgery after AKI. Here we see that it very nicely discriminates AKI from no AKI, and it also works in other settings. This is any surgery. So you see here the kinetics of stage 2-3 AKI and stage 1 AKI and no AKI. So of course the next question is, what should we do with this information? And this has been proposed in multiple works, that we could allocate resources specifically to the higher group and remove the patients who are at low risk. And that leads us to the next point. So if we know which patients we do not need to worry about because they're at low risk and they will most likely not develop AKI, we can discharge them from the ICU and restart the ACE inhibitors and everything, because it's probably not important. They will not develop AKI. And that's what they did in this study. So Sarbrok and his group, they measured TIM2-IGPP7 in all cardiac surgery patients after the surgery, and about 1/3 of them were positive, and those patients got the KDIGO bundles. So they identified the high-risk patient with biomarkers, and they did what the KDIGO guidelines say, avoid nephrotoxins and optimize volume status and so on and so on. So this was the optimization protocol for fluids and inotropes, and actually many patients got a lot of inotropes, which was actually or maybe the secret ingredient. And the results have been shown before by Professor Ioannidis. You see that the AKI rate dropped dramatically from 70 to 55%. Remember, those are all high-risk patients. They all had biomarkers positive. And the severe AKI dropped from 45 to 30%. So the new AKI consensus statement on cardiac and vascular surgery is out now, and it contains probably the most comprehensive and evidence-based recommendations that we have in that field. And in the following slides, I would like to summarize some of them. So with regards of the preoperative care, we can reduce renal risk in some ways. First of all, we should withhold ACE inhibitors and ARBs, and this is also likely to be true for aldosterone inhibitors. Statins can be continued, although there is no suggestion that they protect, and we should avoid contrast media, although I know that this is a topic that will be maybe changed in the next years a lot. And we should consider spacing out the diagnostic cardiac care from cardiac surgery at least 2 or 3 days, ideally, and give the contrast media, if possible, prior to hospital admission. But this, as you see, has not that good evidence. And with regards to remote ischemic preconditioning, studies have shown conflicting results. And the first big study in that field was done by Starbuck, and you know that very well, that RIP significantly decreased AKI and renal replacement rate. However, many other studies which had unselected patients and a non-standardized intraoperative technique that was in contrast to the Starbuck study, they did not show any benefit. And to summarize, the 2017 Cochrane review, which included 28 randomized controlled trials and almost 7,000 patients, they showed that it leads probably to little or no difference in AKI, renal replacement rate, hospital stay, and death. However, in a subgroup of patients who did not receive propofol, the AKI rate was lower, suggesting that propofol may counterbalance the protective effects of remote ischemic preconditioning. And of course, this led to the recommendation that it's not maybe something we can use at this stage in every patient. And with regards to further management of acute anemia during cardiopulmonary bypass, which is associated with more AKI, all of these studies are retrospective, and they seem to show an elbow curve with increased risk of AKI as the hematocrit dips below 20 or 21. And this seems to occur irrespective whether the patient gets transfusion or not, and actually transfusion itself seems to add some risk to this patients, although a recent study suggested that anemia is less well tolerated when hypotension is also present. And with regards to patients in whose the blood pressure management is done without the use of cardiopulmonary bypass, the duration of time when the mean blood pressure drops below 55 seems to correlate quite tightly with the development of AKI. And it is not only the acute drop of hematocrit that is associated with AKI, but also the use of more than 2 units of red packed blood cells that is associated with more AKI increases of damaged biomarkers. But of course, it remains speculative whether it's the transfusion itself or is it just because the patient is more sicker that he has more complications. That's the reason why he just received more blood transfusion. But at least we can summarize that it makes sense to optimize the hemoglobin level before the surgery and minimize the blood losses. Bicarbonate had no effects. And with regards to optimization of the perfusion and probably also decongestion of the right heart, many of us will look at the goal-directed therapy. And as we all know, there are 3 strategies for that. First of all, we have the inotropes, we have the fluids and inotropes. And it turns out that the greatest protection against AKI is with a strategy that includes no greater fluid administration and use of inotropes, nor epinephrine preferably. And this is also in accordance with the KDIGO bundle study with the biomarkers done by Starbuck, who also used that protocol. And finally, we noted already that starch should be avoided. This is also consistent with the recommendation that we have in septic patients, and we should use balanced crystalloids rather than saline to replace fluid losses. So to come to an end, AKI after cardiac surgery is frequent. Clinical AKI may be the tip of the iceberg, and we have biomarker evidence of injury. And the loss of renal function reserve is a very interesting phenomenon, both in terms of identifying the high-risk patient before he goes to the surgery and also monitoring them on the long run. And prevention of cardiac surgery-associated AKI is not that easy, and it relies on identification of high-risk patients. For that, we have different strategies, biomarker risk scores, and identification of pre, intra, and postoperative risk factors. And adherence, finally, to the KDIGO guidelines seems to protect those patients. And with that, I would like to thank you for attention.